Hi and welcome. We are here at Collision. I'm so excited to introduce Dr. Alika Lafontaine, who will be talking today a little bit about data sovereignty. And we are the Greeners podcast, and we're so excited to actually finally meet Dr. Alika Lafontaine. So without further ado, I'm actually going to get him to introduce himself.
Yeah, so I'm Alika Lafontaine. I'm president of the Canadian Medical Association, Metis physician, born and raised in southern Saskatchewan, and have been working in equity and diversity and inclusion for the past couple of decades.
Amazing. Thank you so much for introducing yourself and coming today. Sarah, do you want to add a couple of words, or do you want me to jump into the questions?
I'll just quickly say we're here at this conference because this is actually important. I think the intersection of healthcare and technology, there's so much that, there's so much potential with these innovations, and I think it's really important that we talk about this in relation to healthcare.
Amazing. Thank you, Sarah. So our first question, we have to jump right into it. So the Canadian Medical Association Journal released an important document yesterday, Considerations for Collecting Data on Race and Indigenous Identity During Healthcare Renewal Across Canada Jurisdictions. What are your first initial thoughts on this document? Because we looked at the names, we're like, hey, where's Dr. Alika Lafontaine's name? But of course, there were some contributors. So what are your first thoughts on this document?
Yeah, so the CMAJ obviously is like a separate organization for the CMA. CMA obviously helps to fund it and support it, but it's really taken a direction which I think has been super positive in the area of equity, diversity, inclusion. There's a previous Black issue that didn't happen too long ago. Before that, there's been some Indigenous specific issues. I think the most powerful part of the document is really bringing out the voices of folks who are leading in this area. It's too often that we assume in Canada that there aren't persons of color who are actually leading these discussions. Right. And I think that that's probably the most powerful part of the discussion, is really elevating those folks who kind of live and breathe this research and have those connections across the country, influencing and framing the discussion. Because at the end of the day, I think the most important part of EDI isn't the fact that we talk about it, it's that we actually do something about it.
Right.
Yeah.
Thank you for that. I'll pass the next question to Sarah.
So there's a term that we just mentioned, which is data sovereignty. So for our listeners who may not know, what is and what does data sovereignty look like for Indigenous people from a healthcare standpoint?
Yeah. I think people understand the concept of sovereignty, even though it's not really that familiar of a word. So sovereignty means the ability to exert control and make choices about your life, right? It's to get value out of the things that you contribute and to make decisions on things that I think some of us sometimes take for granted, like our access to healthcare and whether or not we're going to choose different options, and feeling free and safe to share information about kind of our medical conditions and other things. And so the data sovereignty question, I think, is unique with Indigenous communities because in healthcare in general, it's often hard for people to have access to their healthcare information generally, but you have a right to it, right? Like if you push hard enough, you can get your information. That's not always true within First Nation communities in particular. You know, that information is fragmented and held by another body, and sometimes you don't actually have a right to that information because of the way that it's housed. And so I think the data sovereignty conversation is really about the value that comes from that data itself. How do you repatriate that into the community? And then how do you make sure that the value flows down to the person who actually owns the data, which is the individual?
Yeah. And I think that's kind of what we're concerned about, right? I think we've seen the history, we've seen how our information can be used to harm us, and I think that's always my biggest concern. As you know, as I'm working as a health equity specialist, I'm always trying to say, you know what, we need to make sure that we do this with the communities. And again, you know, thinking about just the past and how data collection and any type of data has been used against Black, racialized, and Indigenous peoples, how do we prevent the past from repeating itself?
Yeah. I think that data wasn't really thought of. We kind of accessed the service and we didn't really think, like, you're collecting information on my gender and my sexual orientation and how many times I've accessed the healthcare system and, you know, the types of medical conditions I've been diagnosed with, the medications I'm on, etc. I think when you look at health data, it's really important to make sure that whoever's accessing it is providing value to the person. Right. So one of the things that I don't think we talk enough about is kind of circles of care and what it actually means. A circle of care to me is someone in that circle is actually helping you get somewhere, right? And in the same way that we've tried in mainstream healthcare to create protections to ensure people weren't just voyeuristic and kind of looking through health data or having access to healthcare data when they're not really providing any value. I think that's one of the principles that needs to be brought into the discussion around Indigenous data sovereignty, especially in health. And then I think it kind of starts and stops. So technologically, we haven't had the ability with software to turn on and off access. It's kind of been you get credentials, you log into your EMR, you can really go into anyone's chart. And then the hope is that you'll audit appropriately. That way people won't be behaving in a way that's harmful. I think you're seeing data systems across the world kind of move towards this way that patients can turn on and off access based on their perceived value, right? And I think more and more healthcare needs to shift towards this idea of a value exchange. Like as a patient, you're coming and what's the value that you're providing? Well, you're providing your information, you're providing, open information about your experience, you're providing your trust, and as a provider, you're helping them navigate towards, that better health that they're really searching for. And so I think the more that we can narrow in on when that value starts and stops, I think the safer it's actually going to be for everybody. Yeah.
Oh, that's amazing.
Yeah.
I think that also we need to really empower patients with having access to their own information, because there's this perception that as healthcare providers, we are the gatekeepers to patients' own information, and it becomes this whole big long process to access your information. But I think there's this also fear from the healthcare community that when someone wants their chart, it's for a legal reason, that it's for something that may harm the organization. And so healthcare providers have become very protective of it. But I wish we could just normalize everyone having access to their own information, because at the end of the day, it does help you make better healthcare decisions. But also part of it would be helping the patient understand the information that's given to them, because they may not understand some of the medical jargon perhaps that's being used. So I think that's important. And so my question to you is, how do we hold healthcare organizations more accountable to this?
Yeah, I think the question probably has two levels that we mix together. I mean, there's a question of how do you keep the person across from you accountable?
Right.
And then there's the question of how do you keep the organization accountable? And a lot of the situations that you talk about where people can't access their information, it's not always the person across from you that's trying to be in your way. It's the hospital or the health clinic or wherever you're trying to get the information saying, well, it's too risky for us to give you all of this unfiltered information. And I think providers have gotten used to this idea that what we write down isn't going to be read by the patient either. Right. And so some people write down some pretty offensive things. Yeah. Like it's not necessarily harmful to the treatment path, but it's just written in a very either offensive way or like poor grammar. Like if there was an AI that could rewrite patient records to have them read nicely, I actually think a lot of folks wouldn't mind their information actually being shared as far as the consults and all that other stuff. And so I think when you're looking at risk, it's important for us to educate patients on like where that risk actually lies. And you make me think about conversations that we've had at the Canadian Medical Association with other stakeholders just about data in general. When we talk about data not being shared, it's really the custodians of the data that don't want to share the data. It's not the individuals, right? And so I think that shift towards the individual actually owning their record. InfoWay has been pushing for this minimal viable record for 20 years now, where a patient can have basic information about what they have and kind of take it around from place to place. I think that's the direction we have to go if we want to simplify the ability of patients to access the system. And then I think another thing that goes hand in hand with that is the only person who's at the center of someone's healthcare is the person getting the healthcare. Right? We can try and redesign the system as much as possible, but there'll always be fragmentation. There'll always be some software API that we haven't tied together, or some database that has like different fields or titles or other things. And if we put the patient at the center, which really means giving them control over the holding of that information and the distribution of that information, I personally think that's the fastest way that we actually put patients at the center of data.
Right.
Yeah.
I'm going to ask you another kind of follow-up question just in line to what we were just talking about, because I think that, a lot of this stems from, not sharing power. Yeah. And I think that, there are those gatekeepers. So what do we have to say, or what are the things that we can do to actually kind of say, why are you holding on to this power where this data does belong to the individuals? Because I think that's actually going to be one of the biggest hurdles that we have in terms of sharing power. I think that's, and just kind of changing the whole idea of this hierarchical system. So what are your thoughts in terms of how we might how we might do that? Sorry.
Yeah, so I mean, any of us that have been repressed, we're well schooled in types of power, and so whenever I think of power, I think of information, the ability to hire or fire someone, access to a physical space, money, all that other stuff. And I think when you look at ceding of power, which is really what you're asking for in the relationship. I mean, I'm an anesthesiologist. Once I start to give you drugs for your anesthetic, you don't have any power. You're kind of you're trusting that I'm going to manage you in a way that's going to be to your benefit, right? And so I think when we talk about power, we have to be very clear that it's ceding power. The structure of these systems, you cannot empower a patient to overcome a hospital. Right? A hospital just has too many resources at its disposal to push back against something that it doesn't want to do, right? And so that ceding of power is a really important starting point. And then the second one is just to go back to that value exchange. I think people forget in the accumulation and management of power that it's actually in their best interest for patients to be powerful.
Right.
It makes a lot of sense for a patient to have control of their information, because then they can make sure everybody knows what they should know. It makes sense for a patient to feel empowered, because then they're more likely to be a part of the treatment planning and be a part of implementation. Because at the end of the day, I can prescribe you medications, but if you don't take them in a way that works for you, it doesn't really matter what I tell you. And so I think that partnership and that value exchange is where I hope a lot of these conversations go. And then it's helping people realize, too, a lot of the things that we project onto patients, that if you access healthcare a lot, you don't care about your health, or that somehow you can't understand your medical condition, or that we have to prepare you to give consent. These things are things that we should just assume. We should empower patients because that's the way patients should be empowered. We shouldn't have to go through this convincing ourselves that patients deserve to be at the table. They're at the table because they're the ones accessing care.
I 100% agree with you. I think that is the whole idea behind the saying that knowledge is power is hugely important. If we can actually hold that information, I think about asking people, just my mom or whatever, it's how much do you know about your own health data? And she knows what she knows from her own standpoint, but she doesn't have all that other extra elements, which I think are really crucial. And again, I think it's just another way that we have to shift the way that we do things, because it's going to be important. And I think that, again, we need to make sure that we do this with the various different communities. So we know data collection is only one step. What is the next critical step in achieving health equity?
Yeah. So data doesn't matter if it doesn't change how you behave. Right? And so I think that that's the end point of everything. When we march to change a law, or when we advocate and try and create a social movement online to get attention to a certain thing, what we're actually asking for is people to hold power to act differently. Right? And then we're trying to help people to navigate towards what they need in a way that is more effective, right? And so if you have the data and it doesn't change what you do, it's like you never had the data to begin with. Right? And so I think when I hear accountability, I think less about an audit of whether or not everything you ever did worked out perfectly, and instead maybe asking the question, so you had this information, why did you make the decisions the way that you did? What types of things were you trying to balance? How are you going to act differently moving forward now that you know that this hasn't worked? And I think if we get back to those conversations, we can shift out of this this punitive culture that exists in medicine, not only for providers but also for administration and people who manage our system. The reality is, some things that you do, you should be punished. There are some things that are lines that if you cross, punishment is something that is required, right? Punitive is sometimes a part of justice. But I think for a lot of things we're talking about in medicine, particularly when it comes to racialization, if the harm hasn't gone to the point, what are people asking for? They're asking for no hostility in their encounter. They're asking to feel like you trust them when they're communicating to you. They want to know that they had the full suite of options, because they haven't been given all the options in the past. And they want to know that as they move forward, they don't have to be afraid that if they lose you, somebody who's connecting with them and creating that safe space, that then they're suddenly going to run into a situation where they're going to feel unsafe again. Right. And I think all those things are very achievable. Yeah. But we often don't let the conversation go to those places in the way that we frame things.
That's very true.
Yeah.
You just made me think of something. A sort of negative label that we sometimes give patients when we call them poor historians. And I think part of it is because they don't have access to their own information. Yep. So they might have heard in passing or verbally, this is what happened to you, or this is the procedure that you had done. But without that information in front of them, it's really hard to actually pass that information along to the next person without having a comprehensive online documentation system. So I think there's a lot of work that could be done. Was there anything else you wanted to share with us today in relation to data or health equity?
Yeah, I think at the end of the day, I hope that the equity conversations kind of move beyond simply describing the problem. There's a really great interview I love from Obama where he's talking about what he looks for in a person when he first talks to them. And he says we live in a world where people are extremely good at describing why the system doesn't work for them and describing why the system is broken, but there's not a lot of doers. And what he says in the interview is, I look for people who say, I got that. So if we can have a generation of doers in this next cohort of healthcare providers, if people who work in equity, diversity and inclusion, get down and actually do the hard work of talking with people that are hard to talk to, and convincing people that are hard to convince, and connecting people who are closed off emotionally, cognitively to these different problems, we're going to see change, right? And so I really hope that the next place after the data is the generation of doers.
I love that. I truly love that. And I think this is where, even though we might have those, I'm going to call them courageous conversations that, we might not see eye to eye across the table, it's important to have those conversations, even if there's that difference in it. And I think that, the power of having that, that time where you can have a conversation with someone, you can share a story, you can really make change. And I really believe that in this room, we do have some doers, and I'm looking forward to seeing the change and what other work that you'll be doing with the Canadian Medical Association. So thank you so much, Dr. Alika Lafontaine, for joining us on the Collision Gritty Nurse podcast for today. So thank you, and I hope to see you around. And I kind of wanted to ask you a little bit about your button, if you didn't mind, for our last I think we have 2 minutes left. Yep. Could you tell me a little bit about your button? It looks lovely.
I've been on the board of the Downey Wenjack Fund for the last I think it's 4 years now, and they focus on reconciliation and school spaces. Okay. So they have a legacy school program where we go out to schools across the country and create opportunities for people to learn and have spaces for reconciliation. And I love wearing the pin because Gord obviously had a big impact on reconciliation. Cheney Wenjack and the experience that he had and the way that his family has moved on, the memory of what he went through in partnership with Gord, I think it's really powerful. And it's a great story of how you have two sides of Canada coming together to build a better future. Yes. And so, I wear the pin whenever I come to reconciliation work. Yeah.
Amazing. Yeah. Thank you for the lap piece. And again, some extra learning. So thank you again so much for coming on and talking to us. And I hope to see more of you, and we're going to do the work together.
Right.
Thank you.
Thanks for having me.